All right.
Okay, welcome everybody to today's FSHD University webinar. Um, we're really delighted to welcome the topic of treating FSHD, a broader view, presented by Dr. Nicol Voermans at the Radboud University Medical Center, and Dr. Nathaniël Rasing, who's a research physician also at Radboud University. Dr. Voermans is a Professor of Muscular Diseases at Radboud University, and she dedicates herself to patients with muscle disease, both in care and in research, with a focus on congenital myopathies and FSHD. In 2023, she became co-leader of the Radboud University's research program for neuromuscular disorders, and she also leads the European Clinical Trial Network for FSHD. And Dr. Voermans is joined by Dr. Nathaniël Rasing. His primary focus is on studying facial weakness, communication, participation, and quality of life in FSHD. And I think Dr. Voermans mentioned he's working on a PhD in that topic. Additionally, he's a neurology resident at, I hope I pronounced this correctly, Canisius Wilhelmina Ziekenhuis. So I will learn Dutch one of these days. So with that, I would like to turn things over to Dr. Voermans and Dr. Rasing. If you want to share your screen.
Yes, thank you very much. Can you hear me well right now?
Yes.
Okay. And then I share my screen. Let me see. Can you see the PowerPoint now? Yes, wonderful. And Beth, I assume that you're going to keep an eye on the questions and answer the questions during the meeting, right? I'm not going to pay attention to that.
You do not need to pay attention, and we'll come back on at the end and also verbalize the questions that are in there to you so you can answer them live.
Yes, thank you very much for the invitation to present this topic. And this is a presentation I gave at the World Alliance meeting in June 2023 in Milan, Italy. And when June invited me to give the same presentation once for the FSHD University, I was very delighted because I think it's very important to keep an eye on the wide perspective of treatment and not only focus on novel treatments being developed in preclinical settings or the trials currently taking place. And Nathaniël was already introduced, but I asked him to join me today because some of the aspects in this presentation are his topic of the clinical PhD project he's doing. We did not make a formal division in which slides he's going to present, but when I'm at that topic, I will ask him whether he has anything to add and if there are any questions about social participation or communication. We see if he can answer it, and you might even have very nice suggestions for his future research. Okay, I'm working at a neuromuscular center in the Radboud UMC, and neuromuscular means spierziekte. Spierziekte is muscle diseases. And we have a multidisciplinary team, which you can see here below, consisting of pediatric and adult neurologists, and pediatric and adult rehabilitation specialists, and a lot of preclinical researchers. The people you see here are mainly the clinical people working in my center. And we are one team, so I collaborate more with the rehabilitation specialist than I do with my colleagues in neurology on vascular neurology, for example. And we are a national center of expertise for FSHD, and we have a strong collaboration with the other location of the expert center in Leiden. And we are one of the centers of the European network, which is called EuroNMD. The Netherlands has 17 million inhabitants, and we had a prevalence study performed approximately 10 years ago, which estimated that there are about 2,000 patients with FSHD. There are 6 neuromuscular centers, and 2 of them, so our center and the one in Leiden, in the east of the in the west of the Netherlands, are FSHD expertise centers. And when I explain to patients or to students what FSHD is, we always start with the typical image you've often seen, probably and we tell patients that it's an inherited myopathy, autosomal dominant, that many patients already have someone in the family, but there might also be a limited penetrance due to which people are the first patients in their family. It affects the muscles of the face, the shoulders, and the upper arms, but that there's a large variation within families and between families. The typical onset is in the teenage years or adolescence, and overall patients with FSHD have a normal life expectancy, so they have a long life with FSHD. And a very nice perspective on FSHD was presented by the FSHD Society in 2022 when Lexi Pappas presented her patient perspective on living with FSHD as a keynote speaker on the International Research Conference. I'm not sure whether this is available as a webinar on the website of FSHD Society, but I'm sure that June is able to point you to the right location. When patients come to my clinic with FSHD, they might have diagnostic questions such as, do I have the same disease as my father or mother? Or are my symptoms indeed caused by a muscle disease? And as a neurologist, I look at the history, so the things patients tell me, but also at the neurological examination, findings of imaging, the findings of a muscle biopsy in some situations, and the results of genetic testing. And originally, there was a very logic order in these investigations, starting with history, neurological examinations, then do a biopsy, and then a genetic test. But nowadays, this is much more mixed. So we start with history and neurological examination, but then we can go straight to genetic testing and perform a muscle biopsy afterwards or imaging afterwards. So the order in which diagnostic tests are performed in a neurological or neuromuscular setting has changed a lot over the last years. Moment. Sorry. That's when patients are diagnosed, they might hear by their clinicians that currently there is no treatment for FSHD. And that's also one of the images on the campaign of FSHD Society from several years ago. And I think that is, and I don't want to be unfriendly, but it's a limited view on FSHD. There is no curative treatment, so we don't have a treatment yet which is stopping this disease or which is repairing the underlying molecular mechanism of FSHD, resulting on resolving the disease. But there are many ways to treat the symptoms of FSHD. And I think once a person is diagnosed, it is very important to focus or to address that although there's not a cure, there are many ways to treat FSHD. And it's important to keep an eye on the difference between treatment and cure. You can find a lot of information about that on internet, but a treatment is much broader. It leads to an improvement in health, but it might not eliminate the disease. And many diseases cannot be cured by a medical profession or by the patient, him or herself, but a lot of treatments are possible. And a cure refers to the process in which the disease is completely resolved. And a cure is possible for certain infectious diseases. You can fully cure from COVID, or you can fully cure from an herpes infection, for example. There are also infections of which you cannot be cured, but you can be treated. And HIV is a very good example of that. But a lot of chronic, acquired or inherited diseases cannot be cured, but they can be treated. I think diabetes mellitus or diabetes is a very good example. It's a chronic acquired disease, and there are many treatments available. And in some patients, it can fully be cured if there's sufficient weight loss. But rheuma, asthma, Crohn's disease, many acquired chronic disorders which can be treated but not cured. And FSHD is the same. It can so far not be cured, but it can be treated. And when thinking about cure and treatment, it's also important to think about different dimensions of the disease. A disease is actually a very limited term where you refer to the pathological process, which is the deviation of the normal, the biological norm, whereas illness is the more broad experience of being unhealthy, which is more personal. And sickness refers to the consequences of this disease in the social situation where a person is in. And treatment can be directed at aspects of illness or sickness and partly also on disease, whereas cure is more looking at the biological process itself, so at the disease level. Well, and cure, as I mentioned before, is not available in FSHD yet. There are treatments being developed currently targeted at the disease process in muscle cells, for example, at the gene level, RNA, or the toxic protein, DUX4. And different approaches we can refer to as cure aim to reduce the dystrophy in muscle cells. You can find very nice information about this on the website of the FSHD Society. This one is a screenshot of last year, probably a few more companies on there. And these companies are all in the preclinical phase or in the phase 1 to 3 trials, such as the REACH trial of Fulcrum, which is on the top gray level. Treatments are much more wider. They are focusing on other diseases which might be present, pain, chronic fatigue, sleeping difficulties, physical inactivity, and reduced social participation. And this shows that treatments focus on other aspects of the disease and that they can address a lot of different aspects which all contribute to quality of life. Okay. To have guidance for these for this treatment of different features of FSHD, there's a lot of information on the website of FSHD Society. For example, on physical therapy, occupational therapy, pain management, facial surgery, breathing, anesthesia, and heart problems. And there's an international guideline for symptomatic treatment, including paragraphs on genetic testing, respiratory strength assessment and home mechanical ventilation, cardiac screening and treatment if necessary, treatment of chronic pain and fatigue, strength training, and screening of ear and eye function. Most of these aspects are general neuromuscular, and some of them are specific. I will get back to the guideline at the end of the presentation. In Europe, this general neuromuscular care is provided by Euro-NMD Centers of Expertise. This Euro-NMD is the European Reference Network I was referring to earlier, and it consists of 85 centers over Europe in which neuromuscular specialists provide care to patients with neuromuscular disorders. And these centers fulfill an extensive set of criteria showing that they have expertise and experience in these treatments. There's a very informative website about Euro-NMD, and the people in the audience who are from Europe will probably be aware of this and might even be visiting one of these Euro-NMD centers. But FSHD treatment is of course wider, and to connect to people worldwide, there's an international organization called the FSHD World Alliance, enabling patients to share experiences, but also to provide education to patients worldwide. And this neuromuscular care is multidisciplinary. And this is an image of a therapist from the UK who presented her results at the FSHD IRC last June in Milan. She presented the results of the FSHD clinic, which is a neuromuscular clinic, which is often led by a therapist, but we aim to organize it around the patient. And that's what we've started in our center, similar as Sherry has done in the UK. We see patients with FSHD once a year or twice a year, depending on which questions they have. And they are called by our nurse 2 to 4 weeks before, and she asks the patient, what are the current problems? What would you like to talk about once you visit the clinic and what current problems need to be addressed during your visit. So we organize a day visit with different clinicians or therapists addressing the specific topic the patient is raising. And that is exactly how Sherry Chatfield in the UK is also organizing this. In the FSHD guideline I mentioned, there's also guidance for genetic testing. As many of you will know, FSHD genetic testing is a complex or an extensive genetic test, and the number of laboratories is limited. This is caused by the fact that it's not a simple change of one letter in the genetic code, but there's an abnormal shortening of the DNA, a certain part of the DNA, and you need to have a specific allele, an A allele, which is present in approximately half of the population. This leads to FSHD type 1, and FSHD type 2 is a more rarer form of FSHD. There are also other ways to test for FSHD, and that is available in the United States by the lab of Peter Jones. Many of you might have been tested by this, myFSHD, and it's a more indirect test looking at the degree of methylation. And that differs among individuals, among healthy individuals, but it's definitely lower in patients with FSHD. And this is a more simple test which is being offered by the myFSHD program of the lab of Peter Jones. And it can show the presence of FSHD in the majority of patients. In the guideline I just mentioned too, the DNA testing of the situation approximately 10 years ago was described. And together with Emiliano Giardini and Richard Lemmers, people you see below, we've been working on a new standard of diagnostics with a clinical evaluation form. And this is currently under review by a clinical genetics journal. Once you get the result of the genetic test, this will be in kilobytes or in units. And this is a conversion table we use because in the past it was usually expressed in kilobytes, whereas we use units now. But it's actually a way to express the size of the DNA fragment. And normally this is longer. And in the patient with FSHD, this repeat is abnormally short. And that is expressed in this number of units. We have performed a large study in the Netherlands several years ago where we looked at large families with a repeat size of 5, 6, 7, 8, and 9 units. And we looked at how many people within this family with an FSHD gene indeed had symptoms. And these two figures show the results of that. In A, you see the part of the patients who are symptomatic, which means that they report symptoms of FSHD. And if you look at the graph of the patient, the families with 6 units, you see at the age of 40 years that approximately 40% of the people with that repeat length indeed report symptoms, him or herself. If you look at chart B, which shows the lines of the symptoms or signs of FSHD, you see that these lines are higher. This means that, well, if we look at the same line at the age of 40, a subject with a repeat length of 6 has an 80% chance of having symptoms or showing signs on physical examination by a clinician who knows FSHD. And I'm just showing these graphs to illustrate that having FSHD caused by an abnormal shortening of the repeat is related to the severity of the disease, but that this is about likelihood of presenting symptoms. So if someone has a repeat length of 7 or 8, he or she might not even have symptoms until late in life or not at all. And that's important to keep in mind, and it makes counseling for FSHD, so deciding whether or not someone can expect to have symptoms at later life, very challenging. One of the aspects in the guideline is also on a respiratory strength assessment. There are two terms being used when you look at respiratory strength. The one is hypoxia, which means low oxygen, and then you have hypercapnia, which means high carbon dioxide. And spirometry is a method to assess the function of the respiratory muscles. And if they function normally, you will have normal oxygen and normal carbon dioxide. But if you have reduced respiratory strength, the carbon dioxide might go up. You're not able to exhale sufficient carbon dioxide then. And difficulties occur initially when people are lying down, or example, in a swimming pool. And because it gives symptoms initially when you're lying down, people might have a disturbed sleep pattern and have symptoms due to that during the day. Headaches, they might have tiredness or sleepiness during the day. They might be short of breath when doing physical exercise. They might even have seizures if they are severely hypercapnic. And people usually do not remark it themselves for a long time. And that's why respiratory strength assessment is important, because a respiratory muscle weakness occurs in approximately 40% of the FSHD people. It mainly occurs in those with the scoliosis, so an abnormal curvature of the spine, and people who are in a wheelchair permanently. But you will probably have heard about this by your clinician. Cardiac screening is necessary when people have symptoms, but it's not that FSHD is in all patients related with abnormalities of the cardiac function. When you perform a cardiac ultrasound, normally you don't find any abnormalities, but on an ECG, abnormalities in the rhythm are observed in approximately 10% of the patients. And this is mainly a right bundle branch block. And this refers to the abnormal function of the nerves in the wall of the muscle tissue of the heart, which are shown here on the right with the yellow lines. And these have an important role in transduction of electric signals in the heart muscle. Overall, this is not symptomatic and not progressive, but it's good to know because there might be an ECG performed for another reason, and the cardiologist who's not aware of FSHD might say, well, but there's an abnormality in the rhythm, and it's good to know that this occurs in FSHD in 1 out of 10 people. The screening of ear and eye function is mainly important in the patient with severe mutations, so who have very short repeat length. This is in a minority of the patients, and this can be performed by audiometry, so a hearing test, or fundoscopy with a view on the retina. Treatment of chronic pain and fatigue is an important part of FSHD treatment, and there's information about this on the website of FSHD Society. Overall approach to pain management in FSHD, and this is an image from the presentation given by Kathy Matthews on the previous version of the FSHD University, is looking at, is there a modifiable cause? Are there specific treatments which work? And she definitely makes a very important point by saying that treatment is a process, it's not a magic wand, there's not one simple solution. So you really have to see what factors contribute to pain and can you influence them. Exercise is an important part of treatment. Aerobic exercise and cognitive behavioral therapy both have shown to reduce fatigue in FSHD. This was a trial performed in my center already 10 years ago, and our rehabilitation clinician, Nicol, performed a trial in which patients were invited to have cognitive behavioral therapy. And this is a form of therapy where the therapist is encouraging the patient to increase the level of physical activity in daily life. And the other group was training on a home trainer. She included FSHD patients with severe chronic fatigue, and they had a 16 weeks intervention with aerobic training or this cognitive behavioral therapy. And both groups, the patients became more physically active, had better sleep, and were less fatigued. And this enabled them to have better social participation either at school or at work. In my center, there was another clinical study performed by the rehabilitation department on occupational therapy. And our occupational therapists are the energy experts in my center. So they really look at what is important for this person to do, how much energy does she or he have, and how is he or she spending the energy on the activities. They performed a study with different neuromuscular disorders, including fatigue, and was also a 16-week intervention in which patients had a self-management group training and others had usual care. And they showed that this self-management group training, focusing on these aspects of energy management, resulted in improvement of walking, better endurance of physical activity, better social participation, and these improvements were also sustainable. So even after the intervention was stopped, weeks later, so 11 months after the intervention, these changes were still present. Lifestyle is an important aspect, and there's nice information on the website of FSHD Society. But if you look at the general population, so not the FSHD population, but the general population, and these figures are from the United Kingdom, you see that a large percentage of adults have a combination of risk factors related to unhealthy lifestyle. And patients with FSHD are just like regular people. So this is also the case in patients with FSHD. And therefore, it's very important to draw attention to this. And I often explain to patients, once you already have a chronic disorder, you have to pay better attention to your body and your general health and your lifestyle than people who are otherwise healthy, because you cannot afford to have an additional lifestyle-related disease. This is another image from the general population from the United States, showing how the life expectancy of the general population is declining, most likely related to the unhealthy lifestyle. And I often explain it in this way to patients. This is a very simple graph of muscle strength in early life, adult life, and older life. The blue lines are the range within normal individuals develop. And you see that a reduction of muscle strength from middle adult life to older life is very normal. That occurs in everyone. And a patient with FSHD might be the red line. He or she is likely to have less muscle strength than peers already in childhood, and the muscle strength is likely to decrease faster than in individuals without a neuromuscular condition. But patients with FSHD at old age might be healthier than their neighbor at the same age who has a lot of other comorbidity or lifestyle-related diseases. And this red arrow shows what you might be able to improve with a healthy lifestyle and symptomatic treatment, as we have been discussing in this presentation. Happily enough, there's a lot of information about that also on the website of FSHD Society, and I think it's great that you're providing that. And it includes not only physical training, but also mental strength training. There's a nice site from Kent Dreschner about acceptance and commitment therapy to improve quality of life. That's one of the modes in which a psychologist can help a patient with FSHD. This is a paper I received yesterday by my colleague Basile van Engelen. It's published in the New York Times already 4 years ago. And it's a very nice article in which a patient with another chronic disorder is describing the 5 things she would have liked to know before she was diagnosed. She found out about it very gradually in the course of years, but she said, well, it would have been nice if someone would have told me. And it's about accepting the fact that you're losing certain things. It's the fact that you're losing certain friends, but also making new friends. And it's a very general story about how to live with a chronic disease. And that's also something, if you're being explained these things either by a clinician or a therapist or another patient or your mother or your neighbor, whoever, this might be very helpful and even more helpful than some of the things neurologists do. Well, and then facial weakness and communication. This is about a study one of our medical students performed, and Nathaniël was following up Sumé in the clinical studies. Nathaniël, I've not discussed this with you before, but would you like to talk a little bit about this, or would you prefer me to continue here?
You can continue and I can maybe add something if
Yes, that's fine.
Yeah.
The patient organization in the Netherlands, Spierziekte Nederland, told us repeatedly that it would be important to look at the results or the effects of facial weakness and what does it mean for communication. And we first started an interview study in 15 patients with FSHD and asked them about what it meant to have facial weakness and how it influenced them. And they told us that reduced facial expression affected different aspects of a participant's life. It was more present or stronger when they were very fatigued. And especially younger participants found it very confronting to have facial weakness. And they were also worried about the unpredictability about it. And they avoid talking about this. Whereas elder patients said, well, if you grow older and you compare yourself with others become gray, they might have another operation, someone might have skin cancer, and people become less beautiful when they're older. And it becomes less of an issue when I'm older. So especially for the teenagers, adolescents, and young adults, this was a main topic. But the most participants in this study were older, so there were only a small number of young adults in here. And we think it's important to pay attention to communication and to tell patients that their facial expression might be different and this might be understood by people who they don't know well. And these are two photographs from Dutch FSHD patients which were published in a glossy magazine. And it was a series of 8 very beautiful photos in which the patients were telling their story about facial weakness. And they did this to raise awareness for this feature of FSHD. And the patient in the middle, she said, well, over the years, I've learned to give subtitles. So if I'm very angry, I'm not showing it in my face, but I will tell someone, you are really upsetting me. And if I'm very happy or thankful, I will tell people, well, I'm very pleased that you're giving me this present and you cannot tell it from my face, but I'm really, really, really very excited about this. And she said, well, it really helps that I'm doing this because people, they don't misunderstand me anymore. And I would have liked to have learned about this more at an early age. This is just a small example, but I think it shows how important it is to talk about this topic. And we wanted to continue our study and invited one of the patients. She's the same patient as on the previous slide on the right. And we discussed the main questions with her. And we're now discussing how we can change this into communication training for adolescents. And some of the research questions she raised were, well, how does facial weakness influence communication? And what does it mean to have a different facial expression in different phases of your life? And how can you create these right subtitles? And how can you compensate with other gestures, for example, with your hands, if you can manage to do that? Another topic is genetic counseling and reproductive options. Sanne Vincente has presented an FSHD University webinar on this topic in the past. And we wrote a review article about that, which you could refer to your clinician, but there are different ways to prevent FSHD to occur in the next generation if you want it. And these are not available in all countries. There are more options for FSHD1 than there are for FSHD2, and there need to be more than one patient in the family. So if you're the only one in the family, this is not possible. But if you're thinking about trying to have children, it's very important to start talking about this early and to be referred to a geneticist. Another thing you have to take into account is that you need to carry on some medical alert card. This is the example of the Dutch patient organization, but the FSHD Society and the Muscular Dystrophy Association also has these alert cards. If you're awake and you have to go to the hospital, then you can always tell the clinician or the nurse that you have FSHD. But if you would be involved in an accident and you would have loss of consciousness, they will try to find medical information on your body, in your wallet, in your phone, or wherever. And then it's very helpful to have such a card or an in case of emergency app on your phone. Another aspect of FSHD we are investigating now is growing up with FSHD. I mentioned before that FSHD often manifests in adolescence or early adulthood. But many of these patients, when you ask them carefully, they will have had symptoms in childhood. And we've performed several studies. We have a natural history study in children showing that there's, when you test them, normal muscle strength with a very simple test in the consulting room, but that these patients are fatigued and might have pain. And therefore we call FSHD an invisible handicap in childhood. There's a strong international collaboration to get new, updated international guidelines. We are currently finalizing these new guidelines, and it's based on the guidelines published in 2015 by Radboud University and many other experts involved, and a guideline which was published in the Netherlands and later translated to English by the patient organization in the Netherlands. And this contains topic of pain, fatigue, mobility, communication, and organization of care, which were topics raised by the patients themselves. June is here showing the results of the process of the international guideline revision at the FSHD IRC in Milan last June. And June might want to comment on that later, but we're really in the process of finalizing it now. And the next step would be a guideline for children with FSHD. So I hope that I've been able to show you that treatment is possible for FSHD. And in fact, it is a required start for cure. If you want to be a participant in one of the trials, it is very helpful if you're being treated in a way according to the guidelines and have profit of all the symptomatic treatments which are available. Because what is needed in clinical trials, well, as a clinician, as a doctor, I need to make sure there's a good registry. We know what the outcome measures are, that we know what the natural disease course is. And these data result from natural history studies. And that we have a trial site in which nurses know all the tests which have to be performed in an FSHD trial. We call this trial readiness, but at the same time, it is very helpful if patients with FSHD have the most optimal health and that they can come to the clinical trial site and they don't have too many other diseases which might be an exclusion criteria for participation. So that's what I wanted to tell, and I wanted to say goodbye from the Dutch patient with FSHD here. And the patient on the left is the same patient which was in the other photographs, and she has another very nice symptomatic treatment, which is her dog. She currently has her second AIDS dog, and due to that, she's able to live independently, which she would not be able to do otherwise. And that shows, I think, very nicely how wide the symptomatic management for FSHD is. I would like to thank all the organizations involved, both in the Netherlands and internationally. I think that was my final slide. Yes.
Great. Thank you so much. I'm going to try to unpin you so that we can all participate in this question and answer session. Great. So we're starting to see questions from the audience. If you're out there and have a question for Dr. Voermans or Dr. Rasing, please put it in the Q&A and we will try to address as many of them as possible. Sorry, my camera needs an adjustment. There we go. I'm here. So I'll dive right in. We have a question regarding research on the impact of diet for FSHD and specifically plant-based diets. What advice or guidance would you give to patients in terms of an optimal diet?
There have not been any specific studies performed on diets. Overall, I think you could follow the guidance of a balanced, variable diet. And we overall, I think there's more knowledge about the fact that a very reduced amount of meat or animal products is more healthy. So that also accounts for FSHD patients, but that has not been tested specifically. And we often refer patients to a dietitian who's part of the FSHD multidisciplinary team at my university. And that's not only when people want to lose weight, but also in some cases when they want to gain weight, but overall to have a check of their diet. Is it well balanced? And mainly to see whether there are sufficient proteins. Because especially if people are completely vegan, they might have, you can't be half vegan, sorry. If you want to be vegan, then you really have to pay attention to alternative proteins. Because for every muscle disease, it's very important to make sure that you have sufficient protein intake. Because if you don't, your body will normally break down muscle tissue, because that's a very good source of protein. That's what you want to prevent.
Thank you so much. We have a couple of questions that relate to supporting muscles, especially muscle regeneration.
Mm-hmm.
So do you think that a good exercise program can help either slow down muscle loss or to help regenerate muscle that has atrophied? And I think we probably need to consider which kind of muscle we're talking about here, but can you address that? And then let's start with that one.
Well, when we recommend patients to start physical exercise, we always start with aerobic exercise, which is cardio fitness, aiming to improve the physical fitness of heart and respiratory muscles. And strength training can be added to that in a limited amount. Strength training should never be the core of therapy or physical therapy in patients with a muscle condition such as FSHD. And if you can grow muscle mass, well, there's a lot of similarity between patients with FSHD and individuals without a muscle condition, because if you are physically very inactive for any other reason, you will also lose muscle mass. So if you have FSHD and you've not been exercising for a long time, and you will start exercising with supervision of a physical therapist or another sports coach who has knowledge of muscle conditions, you will probably improve muscle strength. It's not that you're reverting FSHD, but you're reverting the effect of reduced physical activity. And the study I was referring to, performed by my colleague Nicol, it was also included imaging. So all the people who were training, either on the home trainer or improving the physical activity in daily life due to cognitive behavioral therapy, she performed MRI scans in these FSHD patients before and after the trial, and she showed that the increase of physical activity reduced the rate in which the muscle fat replacement took place. So it's not that you're stopping the fatty degeneration, but you're definitely slowing it down. So I think it's a long answer, but I want to say if you've lost muscle as a result of physical inactivity, you can definitely gain muscle strength and volume again. And overall, a physically active life will reduce the rate of decline in FSHD.
Great, thank you. We have a question on the use of electrical stimulation therapy. So if maybe due to what muscle weakness, you're having difficulty actually using a muscle that is still, has potential to. Do you have any experience or thoughts about the use of the electrical stimulation in a rehabilitation program, I guess?
No, we've not used it, and I'm not aware of any trials which have been performed on electrical stimulation in FSHD. It is a treatment being used if there's a primary nerve problems. So if the muscle is not innervated in the right way, you also get loss of muscle mass and strength, and then you can try to improve it by electrical stimulation. But if the primary defect is in the muscle tissue itself, you might increase electrical activation, but the motor itself is the primary defect, and that might be not as efficient.
I have another lot of questions related to muscle health. There's often a lot of concern about statins, which are widely prescribed to lower cholesterol, but have some muscle effects. What do you advise people who have those concerns?
Well, the first advice is primary prevention. So that's a healthy lifestyle, which might prevent you from having to use statins at a later life. And if you're already at that point, that's of course a very unhelpful advice, but it's good for the young people who are here. And then if you need to use statins because of reduction of risk for a recurrent cardiovascular event, we always say start low and go slow. Having a muscle condition itself is not a reason not to use statins beforehand. So you can try it, but you can ask the clinician to halve the dose, for example. And if everything is fine, you don't get myalgia, you don't remark a change in muscle strength, you can increase the dose to the normal dose after a month, for example. And that's how we do it in our clinical practice.
Okay.
There was June, I can send it to you, but David Hilton Jones is a UK neurologist who is now retired, but he gave a very nice presentation on this topic on the WMS several years ago and wrote a review about it, but I will send it to you.
Oh, that would be great. I would love to see and share that. Let's see. Oh, many people have concerns about muscle biopsy, either because they're participating in a study that involves muscle biopsy, and I think sometimes it's still something that's done as part of the diagnostic workup, but can the muscle recover after, if you have FSHD from a muscle biopsy?
Yes, it can recover. And I think there's not a difference between individuals with or without FSHD. A muscle of needle biopsy, and I assume that he or she refers to needle biopsies. That's the way we perform biopsies because the scar is much less and it heals faster, but it's like a micro trauma to your muscle. You could also have a soccer ball being punched to your leg. That's similar. Then you also have a micro trauma to your muscle, and that's what a muscle biopsy, a needle biopsy is as well. It will recover, and not in a lesser extent because of FSHD. It's just that we really discussed this when we talk to pharmaceutical companies. Do you need a muscle biopsy as an outcome measure in your trial? Because we will include patients in a trial now, which might be a next trial in 4 years and another trial in 8 years, because not all drugs which are being tested will be successful. And there might be drugs which help a little bit, and then there will be a trial with aims to improve the muscle strength a little bit after that, etc. So you might have combinations of drugs, and people might end up having 10 needle biopsies in the past, and that's not what we want. I think if you have 1, 2, maybe 2 on each side with needle, that's fine, but you don't want a person to have 10 needle biopsies after 10 years. And we're really careful about it.
Thank you. Here's a question regarding testosterone and human growth hormone, which there's certainly a body of literature around how that increases muscle mass, and there has been a pilot, a phase 1 clinical trial on this. I think patients might be tempted to try this. If they were to use human growth hormone or testosterone, how does that impact their eligibility for clinical trials?
Very good question. I've not seen it as a specific exclusion criteria for trials. Most often, but that's maybe because we've not been sufficiently aware of that, because corticosteroids are always an exclusion criteria if a person is still on corticosteroids, so prednisone for more than 5 milligrams a day, or has used this in the past 6 months, for example. Growth hormone or testosterone was so far not really included in these exclusion criteria, but I think it should. And what we are maybe insufficiently aware of is that people get a hold on these drugs, not through their clinician, but through other ways. And at least in the Netherlands, a lot of young, healthy people who go to the gym and want to grow their muscles, they start using these drugs. And it's really quite a big issue in the Netherlands that a lot of these young people start having, well, of course, they are very musculous and very good looking to some people, but they start having all medical problems, which are the side effects of use of these drugs. And I think, well, as I said before, if this is an issue in the general population, it's also an issue in the FSHD population who might use these medications for another reason.
Yeah.
And so far, I said, I mean, I haven't seen it as an exclusion criteria, but I think it should be. I would be interested to hear how often this is being used. People cannot raise hands here, but they're happy to reach out to me by email.
Okay, thank you. We have a question here about hypercapnia. How do you screen for that? Or how do you, what are warning signs that patients should be aware of?
Very good question. There are different ways to measure it. You can measure it directly by a puncture of the arterial blood, which is performed in the wrist. So you do an arterial puncture here. Well, you don't do it yourself, but a clinician can do that, an arterial puncture, and then you can measure the oxygen and the carbon dioxide in the blood. The spirometry is an indirect measure in a way because there are normal values for your lung capacity. And if it is below a certain level, an amount of liters or the speed, liters per second, for your age and your sex, you're likely to have insufficient muscle strength to have normal exchange of oxygen and carbon dioxide, and that might be a risk factor for developing it. So in the clinic, these are the two ways to measure it. And then the additional way to measure it is if you have an overnight measurement of oxygen and carbon dioxide in a sleep center or a sleep study. What you can remark yourself overall is that the quality of sleep is less, that you wake up more often during the night, that you feel drowsy in the morning, although you might have had 8 or 9 hours of sleep, but you don't feel fresh and full of... You don't feel fresh in the morning as if you were more rested than the evening before. And during the day, you might also have headache in the morning, and headache which disappears when you're sitting up for half an hour, or a few hours. And during the day, you're often more sleepy, and you might even fall asleep while you don't want that at all, while watching TV or reading the newspaper or even listening to someone talk. And that's the result of the reduced quality of sleep. So headache, morning headaches, and sleepiness during the day, and unrest, not a continuous sleep with nightmares, etc.
Okay. People have heard about the possible role of inflammation in HD. Is there any data or justification or rationale for using non-steroidal anti-inflammatories to try to reduce the impact of inflammation?
Well, also a very good question, but that has not been tested in large groups of patients, and it is most likely a very using NSAIDs would be a very broad scope to reduce inflammation. It's not something you could use for a long time. And the results in FSHD so far have shown the role of certain parts of the inflammatory process. And I expect that this will lead to preclinical studies addressing or using more specific approaches to reduce inflammation. So not an overall broad approach such as ibuprofen or naproxen, but more targeted immune treatments. And there's a lot of development in this field for different primary inflammatory disorders, such as Crohn's disease or multiple sclerosis. And most likely, when we learn more about inflammation, FSHD, some of the very specific therapies might also be applied to FSHD. But I think that will take a while.
Circling back a little to kind of supplements, a question on supplements. There were two. One is on antioxidants. Is that useful? And the other is there a daily protein, a recommendation for daily protein intake for people with FSHD?
Well, there was a French study about supplements, but I don't know the results by heart, June, but you might be aware of that it was several years ago. It's not part of the guideline. And what was it? Was there one chapter in the new guideline development about supplements? Do you know
that? It will be touched on. So there were, I would say, modest impacts. So across the outcome measures, many did not show change, but a few did, I think in the quadricep muscle strength or something along those lines. And I think the group in France now is thinking that these supplements need to be really customized to the individual. They do a analysis of each person, and so they're trying to develop some tools and along those lines. But so that's where that stands, I think, as far as I understand.
Well, and then the protein intake is dependent on your age and sex and physical activity. So it's not that I can say you need so many grams of proteins a day. I think it's something where you could talk to your dietitian and talk about how physically active you are, what your current weight is, and then he or she can give a personalized advice. That's much wiser than me just giving a general amount.
Yes. Okay. There was a question also about creatine. Is that safe and useful?
Well, safe, I think it is, yes, but there's not sufficient proof now. And I'm quite modest because it's not in our Dutch guidelines, so we don't use it. But I was not in the working group on supplements and dietary advices. So there I'm also looking to June again, whether she's aware of that. I've not read that chapter yet.
Okay.
Was there anything on creatinine in the current guideline development?
Oh, I don't think so. But I would have to review that too. Let's see, we're almost out of time. One question from a family with genetically confirmed FSHD. There's a member who has severe scoliosis, but the genetics are negative. So I don't think that person would have FSHD. The scoliosis is not related to the FSHD, correct?
It is,
So,
if there's quite severe axial weakness. If the paraspinal muscles are weak, someone can have scoliosis, but that's not the only feature of FSHD then.
but they're genetically negative. They were
Yes, so
tested.
that's not an FSHD patient, and unless the tube have been interchanged or something. But if we are very convinced that someone have FSHD and the test is negative, we retest. And the chance that it happens is, of course, very small. But if it's a positive family and the individual has very typical signs, you should consider this. If it's only scoliosis, then it's more likely not to be FSHD.
Okay. So we are out of time. There were a number of requests regarding exercise, and we, from the clinical studies and also just from patient testimonials, we know that it can have a very positive effect on patients. And one of the problems is that many patients don't have access to a physical therapist or trainer who understands FSHD and can individualize the therapy for that individual. And I think it also takes patience. It can take a long time to see improvement, but we've heard of many patients who do see improvement. So I think we have guides on our website on how to train your physical therapist. Basically, assume that they don't know much, or you can go to a neuromuscular center where the therapist there likely will know more about FSHD and kind of start there. But I think people need a lot of help and access to resources to do that.
Yes, and I think that's a very general advice for people with rare diseases. Don't get frustrated if you have to explain clinicians over and over and over again what your disease is, because that's what you will encounter wherever you are. And it is simply the result of the rarity of your condition. And if you're happy and always try to see the positive side of it, like, well, I'm going to teach this person something, then it makes it more easy for you, but definitely more easy for the clinician to help you. So you are the expert on FSHD, and the clinician is the expert on physical therapy or occupational therapy or diets, and together you're strong. And that will happen, well, not in the FSHD center of expertise, but still I'm learning a lot of patients also. And if you're in a center where that is not a disease often seen, you will have to teach your clinician.
Finally, we have some patients out there who say, how can we be seen? We're outside of the Netherlands. Can we come and be a patient at Radboud? Is that possible?
Well, we can have a video consultation, but for me, it's very difficult, of course, in a video appointment. But I think, June, you have quite a good view on what is available in the United States or in other countries where you are. And if you're in Europe, you're happy to reach out, and I will see within the European Trial Network who's a clinician in your country, because I think I can help you or have a conversation once, but for the long term, you will have to find it more nearby.
Right. Well, if they come to the Netherlands, do you take patients from other countries if they're physically traveling to your center?
Yes, well, we have video consultation for people abroad. Sometimes people come from abroad, mainly from Europe, so traveling distance, Germany, Belgium, we're all very nearby. We're very small. So that happens all the time, but not very often for the United States. And I think I would be very honored if someone would come all the way to the Netherlands to see the tulips and me. But for the long term, it would be much better to have a clinician nearby or in a distance where you can travel also at a later moment.
Right. Well, thank you so much.
Well, maybe Nathaniël has anything to add, or maybe he wants to tell a few minutes about the review he has just published, which he can send to June about facial weakness and approaches. Is that okay, June?
Yes, absolutely.
Research is focusing on the facial weakness and the psychosocial consequences in FSHD. And one of the things we did was making a review, so literature search on all the available information on it. And because we expected to be less information about FSHD patients, we have also focused on other neurological diseases with similar facial weakness of altered facial expression. And we saw that it was that psychosocial dysfunctioning or less functioning than needed was a common theme in multiple diseases. We saw it in the FSHD population, but also in Parkinson's disease with hypomimia and in Bell's palsy. So in multiple diseases with similar less facial expression, we saw that it was a theme what was in multiple patients a major topic. So that was the main outcome of our review. And especially at younger age, we heard that it was a topic. The photos we saw in this presentation of the FSHD patients, she told me about simple things as being at younger age as a child to have the school pictures every year. It was a big event for her because every time she had her most beautiful smile, she just get comments of, "Can you smile for me?" So that was for her one of our major things in back then, and that made a big impression on me.
Yeah, we think that when you, as parents or as clinicians, can talk about this to patients or prepare parents that this might be an issue, these children will be supported in this and might not be surprised or upset by such a situation. So we can strengthen children and adolescents for these difficult situations. And we can learn from the approaches in other diseases. And Nathaniël will continue working on this with another review about approaches and also about a clinical study at our FSHD expert clinic.
Great. Well, we look forward to hearing about that in the future and to sharing those new findings as they come out through another webinar. I'm sure we'll invite you back.
Well, thank you very much.
Today, thank you. Thank you so much for being here. Thank you to our audience, and I'll bring back Beth for some closing messages.
Yes, yes. Oh, thank you everyone for attending our webinar today. We realize there are many questions still left unanswered. We will try to get to them. We always look back at the questions from our chat function, and if there are unanswered questions that we can get over to you, Dr. Voermans, if you don't mind, we'll try to do that. But thank you, Drs. Voermans and Rasing, for all the excellent information and insights today, and for answering all of our questions today. Very, very much appreciated. Our next FSHD University webinar is on Thursday, February the 15th. Our guest speaker is Andrea Klein. She's going to discuss how to monitor and manage breathing issues that can arise in people with FSHD, which is one of the topics that we talked about today, right? So be sure to visit our website events calendar for all of our upcoming chapter, wellness, educational events. Thank you again for joining us here today, and we will see you next time. Take care, everyone. Bye-bye.